Melhaqui and Augusto, how are you? Can you hear me? I unmuted you. Melhaqui, Howie, how are you? You don't have to put your photo there. Augusto, how are you?
Fine, Msindo here. I'm same Msindo, you know.
Oh my, you use a different name.
Yes, Msindo when I use Facebook.
Oh, how you doing today?
Today it's going well.
Okay, okay, I'll be back, okay?
Thank you, thank you.
Okay.
Como vai mesmo, pá? Yeah, nice, pá. Você que mandou a variedade aí do 1 mês e meio, pá. Não, mas como vai-se trabalhar mesmo? Depois, quando te chama, só irrita, só, né? Yeah. Mas, Respa, como é que vai? Ah, yeah, 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 yeah. Yeah, yeah, yeah. Yeah, yeah, yeah. Ah, yeah, sabes que eu tentei ligar para si, mas sempre tive corte, né? Ah, yeah. Nada. Nada, bota como ficou em peso. Falta transformar só em peso aquilo aí. Não há maneira. Pô. Quando descobres outra fonte de taco, pô, yeah, não há outra forma. Yeah, yes. Hum, é, pô. Ah, pô. Sabe, esse tema aqui é continuação de que o que mesmo apresentou. A abscessa epidural, eu enviei, mas é subdural e epidural. Então, é uma continuação, é uma coisa cansativa, na verdade. Cansativa. Coisas. Yeah, fatores etiológicos. Hum. É, é isso mesmo, é ter razão. Porque imagina lá, falar da abscissa epidural, primeiro já epidural, subdural, depois falar da abscissa cerebral. Que é isso? Diagnóstico diferencial é quase a mesma coisa. E como diagnosticar é a mesma coisa. Ah, cansa, só cansa. É só para enriquecer aqui os outros artigos. Sem artigo, você vai falar só pouco, depois parar. Yeah. Então, disse que é, pá, não vale a pena. Me como confirmou a redução, pá. Yeah. Yeah, yeah.
Greetings, everybody. Hello, Abdullah. How are you today? Can you hear me okay?
Yes, I can hear you now.
Okay, great. Yeah, I'm sorry. That was me. I didn't have the right microphone.
All right, okay.
Oh, man. I've done that before. Actually, it was an inopportune moment when I was talking to someone from Johns Hopkins. And it was, and then after the conference was over, I thought, oh no, I didn't have the volume button turned on. Okay, you have any questions? You all set with the screen share?
I'm okay. I no question.
Because we start in 3 minutes, okay?
Yes.
We got some time if you want to go over it.
Oh, okay, for me to go over my slides.
Well, if you want to just practice screen sharing, let me see if you can screen share. Start it.
Okay. Can you see that?
Yeah, yeah, you see it too, right?
Yeah.
You need to get it bigger than that. There's another, I believe it's at the bottom. Yeah, there. One of those buttons at the bottom of your PowerPoint.
Right.
There you go. See how big it is now?
Yes, yes.
Yeah, that's better.
Yeah.
Okay, now to get off it, you know how to get off it, right? Because I want to introduce you first.
Okay.
Yeah, I was just talking to a resident from Nigeria, from Lagos yesterday.
Okay.
Let me get his name. Zolo, can you hear me? There you are.
Hello, Dr. Ben. I can hear you.
How you doing?
Yep.
So you have, yeah, Ulrich said that you're going to moderate. That's fine. Okay.
Yep.
So what I'll do basically, well, I'll introduce you. I'll introduce everybody. Okay. And then you take it away and you moderate, you know, the questions, etc. And I'm going to stay in the panel. Okay.
All right.
Okay. Have you met Abdullah yet, Zolo?
Yes, Dr. Ben. Good morning, Dr. Abdullah.
Dr. Jamo, yeah.
How are you, Zolo?
Zolo's helping me promote the website. He's a medical student from Cameroon.
Okay. That's really nice. I hope you
we haven't started yet.
Beru, yeah. You know Beru?
I'll let you know when we start, okay?
Dr. Ben Juberu, Zolo. Have you heard of him?
I did not get your question.
Juberu.
I did not get your question, please, doctor.
I say yes. Do you know Dr. Juberu is a neurosurgeon in Cameroon?
Do you know him, Zolo? What's
not
his name?
Personally, but
You've heard of him?
I've heard about him. I've seen, yes, but not personally.
Okay, great. It's nice.
Okay, you guys ready to start?
We'll meet him someday.
Okay. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon. This is Dr. John Bennett broadcasting from Miami. We have the first in the African Neurosurgery Grand Rounds. We have the pleasure of having Abdullah Minoa, the neurosurgeon from Nigeria. And I'm going to hand it over to the host of today's program, Zolo. Hello, Zolo. Take it away. Zolo, are you there? Well, I guess I'm going to... Go ahead, Zolo. Go ahead.
I'm facing some difficulties.
Okay, I'll take over then. Okay, no problem. Let me introduce the panelists before we turn it over to Abdullah.
All right.
First, Zolo, could you please introduce yourself?
Yes, I am Zolo Ivan. I'm Zolo Ivan. I'm a medical student from University of Buea in Cameroon. I am a member of the Association of Future African Neurosurgeons, and it's a pleasure for me to be here today.
Welcome. And Augusto, Musindo. Can you please introduce yourself, Musindo? I know you're on a different account name today, right?
Musindo.
Go ahead, introduce yourself, please.
I am Augusto Musindo, resident of neurosurgery in Maputo Central Hospital in Mozambique.
Okay. Welcome. Stefan, are you there, Stefan? Go ahead.
Yes, I'm here. Hi, everyone. My name is Stefan Gembu. I'm recently medical general practitioner from Cameroon.
Welcome.
Also member of EFAN.
Welcome, Stefan. Dung Guga, I don't believe we've met. Can you please introduce yourself? Can you hear me okay?
That's my reference from Nigeria.
Go ahead, Dung.
Yes, I can.
Please introduce yourself.
Yeah, hi, everybody. My name is Dunguga. I'm Dunguga, a resident neurosurgeon here in Nigeria, currently at Enugu, University of Nigeria Teaching Hospital. But Dr. Jimo is my boss, my first trainer, and I'm privileged to be a part of the presentation this evening. Nigeria, currently at Enugu.
All right, great, Dong. Welcome. Joseph, could you please introduce yourself? I don't have your last name there. Go ahead, Joseph.
Hello, everyone. I'm Dr. Joseph Obande.
All right, great. Welcome. Joseph.
University of Abuja Teaching Hospital, Abuja in Nigeria. The presenter, Dr. Jimo, is my trainer. I'm Dr. Joseph Obande.
Okay, excellent. Okay, and Dal Guinevere, please introduce yourself. Oh, Dr. Go. Can you please introduce Nadal?
Yes, good evening, everyone.
Hey,
my name is...
Please introduce yourself.
Yes, good evening. My name is Indale Genevieve, 4th-year medical student in the University of Buea.
Okay, welcome. Okay, let me just turn off some of the people.
Thank you.
Okay, Malhaku, can you please introduce yourself?
Yes, Dr. Adil Melhawi from Rabat, Morocco. Hi, sir. Nice to be here with you all.
Welcome. We have another Moroccan neurosurgeon here. Banko, are you there? He may have stepped away. Okay, very good. Okay, Abdullah, welcome, and could you please introduce yourself, where you practice, etc., before you start your presentation, and welcome. Okay, very good. Okay, Abdullah, welcome, and could you please introduce yourself, where you practice, etc. Go ahead, Abdullah, are you okay?
Yes, I'm okay.
Okay.
Thank you so much, everyone. I am Abdullahi Ojimo. I'm an associate professor of neurosurgery in Nigeria, Ahmadu Bello University Teaching Hospital and Ahmadu Bello University in the northern part of Nigeria. I am currently in Rabat for fellowship. It's a pleasure to have everybody here, and I'm actually delighted, and I hope that we'll have a good time here today. In the panel is Professor Adil Melhawi, who is my first, actually, I work directly under him here for the fellowship. And I also have Dr. Obande, who is a neurosurgeon. He is working in northern part of Nigeria as well. Was my first trainee. Then I have Dunguga, also my resident, who is currently somewhere in the southern part of Nigeria training. Without much other issue, let's go ahead straight into the presentation. I'll be presenting Lexel Gamma Knife Radiosurgery. It's an overview of principles and the operations of Gamma Knife Radiosurgery. Hello, yes.
Yes, we can hear.
Yes, my first slide is two pictures up there are my institution. I work with the university as a lecturer and also as a consultant with the teaching hospital. I'm currently, as I said, on fellowship in Rabat at the Hassan II Foundation and the Center for Nervous System Diseases and Neurorehabilitation. And specifically, I'm working under Professor Melhawi in Gamma Knife Radiosurgery Unit. Now, everybody knows Nigeria. Nigeria is the most populous Black African country in the western part of Nigeria. 200 people in the western part of Nigeria, and up there on the left is the flag of Nigeria. There are no disclosures. Khamlishi, Professor Wahabi, Professor Arha, and Professor Melha, who is part of the panelists this evening, and also my institution there in Nigeria. Now, let me start by introducing the topic. It's a long discussion. I will start by saying that it's a non-invasive form of surgery, a type of radiation therapy, but it's actually a surgery carried out by neurosurgeons, called surgery because of its single session treatment without incision. Highly precise delivery of radiation in sub-millimeter range, 0.1 millimeter. You can imagine the precision that is. Relies on 3D images acquired by CT and MRI. And in some instances, 2D images are also acquired in vascular pathologies where angiography is done and incorporated into the planning for the treatment. We determine the location of the target. Highly focused gamma rays are given to the target, and due to some biological changes, treatment is given to the tissue within the cranium. Improve accuracy of delivery, has broad range of clinical application, as you'll see soon. Also known as stereotactic radiosurgery, a type of radiation treatment used commonly for brain tumors and other abnormalities of the head. Investigated in 1950 by Bud Larson and Lars Lexel. First gamma knife device constructed in 1967 and used on patients in 1968. Requires no incision. The history of stereotaxy. In humans, over time, we've known the brain or central nervous system generally to be housed in a very rigid casing with very eloquent areas. Indeed, the brain is very amazing. So over time, people started inquiring on how to get a precision to those eloquent areas without causing collateral damages. In 1908, Victor Hosley and his colleague Robert Clark devised a material, a stereotactic material based on geometry to reach a precise part of the brain for some procedures. Over time, nothing much was done again until 1947 to 1949, when two stereotactic devices were brought into brain surgery. Those carried by Henry and Ernest and Lars Laxton in Sweden, that was later Electa or as Electa. In 1978, American physician Russell Abraham implemented CT use in stereotaxy. Now, part of the history still, gamma knife was developed by, like I said, Lars Lexel and his colleagues in 1968 on use on human. It was introduced in the US in 1987, almost 20 years after it was used in Sweden. Over 1 million people have been used, and specifically, actually, as at last year, I know 1.2 million people all over the world have had the benefit of being treated with gamma knife radiosurgery. Now, this is the picture of Lars Lax in 1949 when he devised the stereotactic frame, which essentially has remained the same up till this moment in principle. And he defined gamma knife radiosurgery as the delivery of a single high dose of irradiation to a small and critically located intracranial volume through an intact skull, that is without the incision. Let's say gamma knife surgery is widely acknowledged as an efficient technique to treat various brain diseases. Now, in principle, this is model 4 gamma knife. It has evolved over several models. I'll talk about that soon. This is a 3-ton helmet, because the source of the material has to be behind a 3-ton helmet that has 201 holes or areas of source of cobalt-60 that are focused on a particular part of the brain that has a lesion with so much precision for it to be treated. Now, over the years, we've had this evolution of the machines, the U model, the B model, the C model, the 4A model, then the perfection, and as a matter of fact, of recent years, we have the...
Num sábado como este aqui vai dizer que não, já tem pessoas lá sábado.
Sorry, there is noise behind, but in any case, we'll continue. The Icon Gamma Knife machine, which we are currently using in the center.
Maybe Dr. John Bennett can mute everyone, please. Dr. John, can you mute everyone, please?
Yeah, I'm sorry about that. Go ahead. We got it.
Now, also, as I've said earlier on, this is actually written information about it. Up to model 4 had 201 cobalt sources to be focused on a target for treatment. However, from perfection up to Icon has 192 and has other features that probably we'll talk about soon. Again, in the previous models, we have these properties. Then perfection came and was better, but the Icon is far superior again because there is possibility of frameless gamma knife radiosurgery using the mask. And also in this Icon model, the couch of the gamma knife where the patient lies in is also mobile with the head frame in adjusting to treatment positions. Now, this is a very important slide to show the importance of gamma knife radiosurgery and how precise it is. Like I said, it is a sub-millimeter, 0.1 millimeter precision. And you can imagine where a lesion is next to organ at risk. What I mean by organ at risk, we'll probably talk about it later, is tissues that might not tolerate high dose of irradiation. Example is optic pathway, the vestibulocochlear apparatus, the facial nerve, all those ones, and the brainstem. They have to be well taken care of while planning gamma knife surgery. Now, the precision is more high up there with gamma knife radiosurgery, and the precision reduces as you go down. So therefore, LINAC is not as precise, of course. It has several sources, over 1,300 sources, which are robotic positioning system, but however, it's not as precise as a fixed G-frame applied treatment by gamma knife. Let me say at this point that the word gamma knife is being used by other manufacturers as well, especially in the Far East, maybe the China region, where the cost of the sauce, which is very expensive for these 192 sauces, but in trying to economize, have devised what we call a rotating frame, which does not in effect give the precision that is needed in this treatment. Now, also, that is exactly what I've said in the previous slide. Now, in basic understanding, I got these pictures to really make one to understand, because it's highly theoretical at this stage. If you are not involved in it, it's a bit theoretical. But let me use these pictures to really show what the whole principle is. As children, that if you use a biconvex lens with under the sun, it focuses the light at the focal length and it burns the leaf or the paper. That is exactly what happens. Now the helmet, you know, is like converges the rays onto a focus, and this focus is where the activity, biological activity, is taking place to treat lesions. The same picture I'm trying to depict here. Now, this, we have to fundamentally, in radiotherapy, images, in gamma knife radiosurgery, beams are applied based on the angle of projection into the lesion. And from the center of the lesion to the periphery, there is rapid decay of irradiation, therefore making it very important or significant in this treatment modality. Now, other machines that were put in place by other people, LINAC and all that, does not have this sharp peak. Instead, there is some area of plateau and the treatment is not as effective. Now, there is another way to look at it, biological specificity. What I mean by this is that when we are doing normal radiotherapy, fractionated radiotherapy, now irradiation is applied to the brain. Now, because the pathological part of the brain has some tissue or chromosomal abnormality, the irradiation at every fraction distorts that tissue, and time is given for it to heal, you know, in fractions, until cumulative effect comes to play only on where the lesion is. Okay? Now, this is what happens. Therefore, the adjacent brain is also affected. But where we are talking of single dose radiotherapy, that's anatomical selectivity, only this tissue here is acted upon. And all the biological processes that happen for treatment takes place only in the focused area. A single dose versus fractionation. By definition, like I said earlier, radiosurgery, single dose, single session, anatomical selectivity. While fractionated, it is fractionated is biological selectivity based on the property of the tissue, normal tissue, and the pathology. Now, this is worldwide distribution of what is going on all over the world about the treatment. Sorry, this is this center here, what we've treated in the last 11 years. That's 12 years, 2008 to 2019. We've treated, and world over is 1.2 million people treated. This is the distribution of what we've treated here. A majority of them, AVM, meningiomas, metastasis, other lesions, other benign lesions, carcinomas, tremor, we'll soon look at it, also functional pathologies are treated. trigeminal neuralgia, pituitary adenoma, vestibular schwannoma. Now, the first application of gamma knife was much more popular for the treatment of AVM, actually. Now, treatment applications, brain tumors, both cancerous and non-cancerous, primary or secondary, vascular pathology, AVMs, cavernomas, and fistulas, dura fistula, functional application, trigeminal neuralgia, Parkinson's disease, tremors, epilepsy, more. In fact, some psychiatric problems, severe depression, obsessive compulsive disorders are being treated and being approved in stages for treatment with gamma knife radiosurgery. Now, the special property of perfection machine, that is the machine before this icon, has best dosimetry performance, unlimited cranial reach, meaning within the chamber, the machine has a room to shift the head of the patient to the area of maximum focus. Since I told you earlier on, it has been perfected so much to the sub-millimetric measure. Full automation of the process, best irradiation, patient and staff comfort, and similar radiation profiling as prior units. Now, Icon has special property, which I've talked about earlier on. Now, it focuses and delivers from 192 sources and beamed via collimator 4 millimeter, 8 millimeter, and 16 millimeter into a target. Only the pathological tissue is affected, and the effect is long-term. Now, it is very important for you to appreciate this curve. How do we know the doses are applied? It is known over time in the past when it was being used that patients were studied, and it was, this is the percentage effect and the dosage in gray. Now, for people with little gray, little is achieved. And as the gray increases, it reaches a point that it starts plateauing. Therefore, this is the point that it is ideal as the best treatment point to give to a patient. Anything beyond that can only give a side effect. Then the next slide is, with this sigmoid curve, also it is known that lesions that are irradiated far more than the tolerable dose tend to have side effects more. And smaller lesions need higher dose than bigger lesions. This actually graph explains it all. Patients are usually referred from other centers, just like any highly specialized field. Patients are fully evaluated by taking adequacy history and full examination. And patients sometimes present with problems that are referable to primary disease in case of metastasis. Common metastasis in women usually is from metastasis from the lungs, from the breast, sometimes from the cervix is seen as well. Kidney, from melanoma. The kidney and melanoma are more radio resistant, but they have doses that are given to them as well. Therefore, other disciplines are consulted to make inputs in decision taking. A group of people during a staff every week, from my experience here for about 5 months now, every week staff is called and all the disciplines interested at stake come into to study, to hear the clinical part of the pathology in terms of the clinical aspect, history, physical examination. The neurosurgeon, of course, will make an input. The neuroradiologist will interpret the images to achieve accurate diagnosis. And where need be, diagnosis might be reached earlier with the help of the pathologist by obtaining stereotactic biopsy, which we do here proficiently. Then after getting histology, or In some cases, patients were treated, managed elsewhere, and because the tumor was not totally removed, gamma knife radiosurgery is used as an adjunct to primary surgery. Neuro-oncologists, neuroanesthesiologists, and others come in to make their input in a highly discussed case, and decisions are made, diagnosis is made, the dosage is suggested, the oncologist is there and also makes an input as to the best form of treatment. This is the typical stuff of what happens in decision-making. Everybody clinically takes decision as to what's going to happen. However, I must state here that this is not a tool that is going to put neurosurgical technique or finesse to the background. No, it is a technique that is used and has its own indication. Where tumors are gross and in a resectable area, it doesn't make sense to apply gamma knife radiosurgery. So therefore, there is a quote here: a fool with a tool is still a fool. However proficient the gamma knife is, some people will not get it right if they choose to apply it, because it has its own contraindication and possible complications. Basically, there are 4 steps in carrying out this procedure. We have frame fixation, acquisition of image, dosimetry planning, and radiosurgical treatment. Now, I have in details dosimetry planning here, which I'll just glide over during the presentation because it's highly technical, but I'll give a general perception of what it's all about. Now, the principle is to apply the frame. The G frame is based on geometry, X, Y, Z axis, and how it's going to be applied. Is, of course, one has to be treated. That's what you do every day here. Frame is applied, image is acquired, treatment planning, another. For application of the frame, we have to obtain consent, well explained to the patient, diagnosis is made, of course. Pre-medication is given, a small operating room, asepsis using chlorhexidine gluconate, or in our center here, we use betadine, though some people say that there is MRI distortion, image distortion, but that's what we use, and we don't significantly see image distortion. Now, local anesthesia, 1% lignocaine is instilled at the level where the screws are going to be fixed on the skull. Propofol is sometimes given to reduce, to enhance the anesthetic, little anesthetic effect. The duration is usually 7 to 10 minutes in applying the frame. These are the frame materials. That is the G frame and the screwdriver and the pins, and also other accessories. It has a lot of other accessories as well. Now, this is how anesthesia is given. For children, I must say here, for pediatric patients, general anesthesia is usually used throughout the procedure because the patient, of course, pediatric patients are usually anxious. To have a frame like that fixed on the head will evoke a lot of anxiety or restlessness, and the patient will be anesthetized from the application of the frame, acquisition of image, planning, and treatment. All through these 4 stages, for a pediatric patient will have to be under general anesthesia. However, for adults, everything is done with the patient awake. These are how the pins are, and there are principles in applying film, especially for the models before the perfection and icon. This is not too important in slide, in current treatment actually. The diagonal line must cross where the pathology is. For a central pathology, the pin applies so that the pathology will be in the middle. If it is in the posterior part of the brain, the posterior pin will have to be longer to push pathology to the central part. That's essentially the essence of this slide. Now, we fix the frame, the same procedure with an assistant.
Then verifying and screwing the frame so that it doesn't come off at any stage of the procedure. Diagonal screwing with the torque of thumb and index finger. The force should not be more than that so that the pin does not cause any local complication. However, in some instances, you can imagine if a patient was treated earlier, had wide craniotomy in place, something like this, and without knowing, you cannot, if you put a pin, you go straight into the brain tissue. So you have to have adequate examination of the patient to know where the craniotomy point was. And there are provisions where there are tripod stands or tripod pillars to avoid where craniotomy was sited. Now, there are pillars that are special for certain particular pathologies. Like in this patient, we need to be in the same parallel axis with the visual pathway. The posterior frame are short and really goes, because we are going to get a obitomeata line or CPAP line. We have to put a frame that will give us that angle of treatment. Like this is the visual pathway that has been drawn here. Now, after applying the frame, we put the fiducial box. We have that for the MRI, we have that for the CT scan, and we have that for the angiogram. This is very important to get the axis, XYZ axis, which is very important in defining the image on the gamma plan, which we'll talk about briefly. Now, like this is the fiducial box for the MRI, fiducial box for CT scan, and fiducial box for the angiogram. This is a 2D image acquisition fiducial box. This is 3D, this is 3D. I mean, the CT is 3D, the MRI is 3D. Now, the image is taken into the MRI with specific sequence request in some instances. I'll talk about that in a slide ahead. Now, frame adapter and frame cap are also tested to be sure that they fit very well. Now, I'll briefly talk about workflow. Now, the workflow generally follows these 18 guidelines, 18 steps, I might say. The 18 steps are graphical user interface. This is highly technical, actually. Create a new patient. You just understand that. We create new patient. Import image. In this center, the image acquisition apparatus are networked into the workstation. The image is networked and imported into the system, which will be upgraded. Then gray scale is adjusted so that you see the lesion very well and see the interface. Then we define the study based on the fiducials. Supplies call measurements, and because at the end you have the measurement of your lesions as well. Is dosage. You give the patient a supply frame count conformation and detailed frame measurement. I guess let me go through the slides. Then this is your graphic, how you acquire image, create the, how you create a new patient, import image, define the image based on the stereotactic. It's a bit theoretical, actually. Then now, it's very important I say this. While defining the image, this point definition is brought to the outer point and the last point before the middle point. Like I said, it's a bit technical. Until the whole points are all green, that means the images are well defined. For a two-dimensional image, that is like angiography, this is how the fiducial is, and this is the principle, how you define the image. That like a vascular issue, the image is defined
based on this cross and star on the fiducial box. Okay, then the frame cap is tested. There are measurements that must be recorded based on the pillars, because it's very important in defining the treatment plan. Now, define any risk organ. There is what we call organ at risk, which I've talked about before, like the optic nerve, the brainstem, the vestibulocochlear apparatus, the cranial nerves where lesions are sighted. They are next to them. There are minimal doses that those organs can take. So there are techniques in which you actually adjust the dose so that it doesn't go to those organs at risk. Okay, let's quickly go to, after defining the lesion, shots are given manually. Shots are given into the lesion until you really conform to all the tissue that is pathological. You start with 8 millimeter shot. After filling up everything, then you use 4 millimeter to actually fill up all the gaps. Okay, that's all we're talking about. We'll go quickly over this thing. Then there are what we call dynamic shaping. Yes, this is also for organ at risk, so that, dynamic shaping has 0, 1, 2, 3, 4. This is, if you can see very well, we can see the organ at risk here, which is the optic tract, optic nerve. So you want to protect it. And this is where your 50% isodose is, and you have to protect it depending on the pathology and the dosage you are going to give. So you apply grade 1, the optic nerve is still not fully spared. You keep going. Okay, the optic nerve is fairly spared more at dynamic shaping level 3. Then, yes, this is the maximum dynamic shaping, and the optic nerve, the two of them are spared. And with this, you can give treatment. Now, this is finally what the topography looks like. You see the visual apparatus is there, marked out, and is spared from the irradiation, the maximum dose that could be deleterious to the visual pathway. Now, after this, the patient, the draft is approved, printed, signed, and exported into the machine. This is signed because it's highly, highly specialized. Then there is another principle of inverse planning. Instead of manually planning this, you can define the pathology, draw it, and assign a dose to it. The machine, the gamma knife, just calculates the dose that is required for the treatment. That's all about the planning. Now, next is post-treatment. On average, within about a day, the treatment should be over. The patient can come back to normal activity, receive follow-up appointment with doctors, and the follow-up is very important. Now, these are the dosages, actually, for various pathologies. AVM, these are the dosages. It depends on the center. Quotations here might even have the quotation of some other centers and how they apply it. But basically, what is shown here is what applies mainly in our center. AVM, this is what is the dose that is given. Acoustic neuroma or vestibular schwannoma, this is dosage. Meningioma, depending on whether it is a grade 1, 2, or 3, a typical or malignant meningioma, the dosages are also stated. However, radiotherapy can be given, and gamma knife booster dose is given as well. Now, there are centers and their own various regimen. that this is a Pittsburgh, this is RTOG, and others. This is a dosage the regimen. Then Karolinska in Sweden, this is based on the size of brain metastasis. This is what they give. Because, like I said earlier on in the presentation, the size, if the size is small, you can give more doses. If it is large, you give less dose because of the effect of the irradiation on the adjacent brain. Now, usually single session, I kept on repeating this, total number of ISO centers may vary depending on the size, shape, and location of the target. Multiple lesions are treated. Each ISO center has a set of 3 Cartesian XYZ stereotactic coordinates corresponding to its location in 3-dimensional space as defined using a rigidly stereotactic frame. I've talked about this in earlier. Then special imaging. Yes, where certain lesions need precision, you need special imaging, special sequences, especially on MRI. Of course, MRI of 1.5 Tesla, MRI that can do 3D reconstruction of the image. So it is extremely important to have the MRI that is meant to support this kind of treatment. Usually for pituitary lesions, we need fast suppression. Then cavernous malformation, variable echo multiplanar, in addition to angiography sometimes. Then thalamotomy in functional procedure now, you need additional fast inverse recovery sequence or DTI. You can get a tractography out of that. Then brain metastasis, double dose contrast with 2mm cut, brain metastasis magnetic transfer sequence, and CISS, that's constructive interference in steady state. This one is used especially at the skull-based T2 image where all the cranial nerve and vessels are defined, very, very defined, especially actually in functional pathologies like trigeminal neuralgia, where you might even see an aberrant vessel that is impinging on that cranial nerve, or thick hemifacial spasm. You can see the vessel that is impinging on the facial nerve. Then results are, you can just imagine this. This is a patient with cavernous hemangioma of cavernous sinus hemangioma that had treatment, and after 6 years, you can imagine, without any cut to the body, you can imagine the result of this. The tumor is more or less 90% gone. Then worldwide, this is the cases that are seen and the that have gamma knife treatment. Then this is another result of a patient with 3 years, 95% survival after gamma knife of a patient that had metastasis. This is another case of metastasis that survived because the primary area was taken care of. Previously, I would go for craniotomy and do this, and the collateral damage can be significant actually. Now, these are 25 lesions, metastasis, and these ones can all be planned and be treated. Yes, and within 3 hours, treatment session is over, and they have, most of them die from the primary disease or metastasis to the other parts. The metastasis to the brain after gamma knife surgery is usually stabilized or even totally fried out. Sorry for using that language. Then worldwide indications for gamma knife radiosurgery. This is essentially this is from Gamma Knife Society, the distribution. And this is a DTI image of a thalamotomy for some movement disorders, tremor. Is highly precise, single target, high dose, and doses 130 gray at a single point. And the result can be very, very remarkable. Following up these patients, benefits do not manifest immediately. It can take 3 to 12 months. However, some lesions, benefit can be immediate. For somebody who has hypothalamic hematoma with intractable seizure, benefits can be within matter of days. You know, the seizure can just abort immediately. And also depend on the pathology. That's why I talked about hematoma of the hypothalamus. Then in seizures, it takes 18 to 24 months. Then AVM, very effective, and you can have up to 80% reduction. Follow-up depends on the pathology. Malignant lesions, initial months, patient is followed up frequently, you know, to see whether there are new lesions and to know what is happening to the treated lesions. Then 3 months, thereafter, after 2-3 months, 3 months and another 3 months, that's after 6 months, patient can be followed up for every 6 months. For benign lesions, every 6 months, both for clinical and imaging follow-up. Thereafter, every 1 year for 2 years. Then after 5 years, then after every 5 years. For vascular lesions, vascular angiography is done after 5 years, after following them up in this kind of lesion. Then assess new complaints, benefits, size of lesion, new lesions, other complications. Advantage: no anesthesia, no incision, no deficit at the end, no infection, no bleeding and the challenges of bleeding. Brain metastasis, because of the multiplicity and the depth of location, can be treated. Unlimited reach to lesions within the cranial cavity. Contraindication is any cause of raised intracranial pressure, massive edema, obstructive hydrocephalus, tumors. Well, in the current treatment, tumor size is not particularly a contraindication. Tumor size, for emphasis, is not contraindication to treatment. And that is why the current use of the words like hypofractionation or staged radiosurgery comes into play. Then increasing to increase compression tumors, that's raised intracranial pressure generally, as I've said, the compensation of the tumor. So in multi-staff meeting, the canopsych performance of the patient must be assessed, because it's a very expensive treatment regime. You can't afford to treat with patients that have very little life expectancy. Within 3 months, patient is going to die, then it will be of no use. Then pregnancy at whatever stage is a complication. Now, complications are very rare, which anxiety, syncopal episodes, coronary event, headaches, facial pain, radiation necrosis. Very important, it's a source of worry to the radiosurgeon, and it is idiosyncratic with patient, and the consequence of that, because of that, we avoid this complication. I'll look out for them after gamma knife radiosurgery. New motor deficits due to edema, perhaps, or injury to the organ at risk, symptomatic hydrocephalus and delayed seizures, yes. Then adverse effect, which is very mild and transient, nausea, headache, transient numbness, fatigue, hair loss, for lesions that are close to the skull, then is very, very expensive. Disadvantage is not particularly a disadvantage. The frame, which some people might describe as a bit grotesque, for frame to be fixed onto the skull for some form of treatment, fairly long duration of treatment compared to LINAC, but the precision is small. LINAC go in minutes, but the precision is not as much as gamma knife. This duration can be, what I'm talking about, long duration, is the treatment duration is not more than 4, 5 hours at most. But some people might see it as a bit prolonged compared to linear. Careful follow-up is needed. Edema and use of steroid where certain complications arise, then organ at risk to support treatment size. Then cost of gamma knife radiosurgery treatment is much, for depending on the pathology across 5 years treatment plan. Then gamma knife surgery is surgery without anesthesia, without any incision, no hair shaving, no infection, no blood transfusion, no death, no disability. Gamma knife surgery is powerful enough to destroy undesirable tissue in the brain without harming surrounding normal brain. No lengthy post-operative care, no loss of productive life. The patient returns to normal life within a day or 2 of treatment. This option is an armamentarium of patient's care and must be reserved for specific pathologies, as it is not alternative to good surgical principles and skills. In medical practice, there are times that consequences of surgical care can be profound, if not catastrophic. And that is what caused the shift in the frontier to get to eliminate all those problems. In the quest to shift the frontiers of health provision, man has continued to use the knowledge of science and computer to foster the cure and care for brain pathologies that hitherto carry grave outcomes. Indeed, the knowledge of this should be made available for practice or for the practitioners to give this as an option to patients they are caring for. In conclusion, a novel and good frontier of neurosurgery. Thank you so much for listening.
Oh my God, it is very nice.
Oh, thank you, Nurdin.
Thank you so much, Professor Jimo.
Thank you so
This
much.
was a wonderful presentation. I don't know if Dr. John is online. I have just one small question quickly.
Okay.
Yeah, thank you so much for this wonderful presentation. It's Dr. Kabulo.
Okay, no, I'm asking if Dr. John is there to moderate.
Yeah, I'm sorry. I was doing some promoting. And thank you very much, Doctor. We're going to open it up to comments and questions. Excellent. Thanks for taking the time. Okay, Dr. Kabulo, go ahead.
Thank you so much. Thank you, Professor Jimo. This was a very good presentation. I really enjoyed your presentation. You know, this is an area where usually we run away from, but I understood many things. I have just a small question I wanted to ask. It's about fractionated stereostatic radiosurgery. Yeah. How do you do that biological selection?
No, hypofractionation, but we in radiosurgery, unlike conventional radiotherapy, in radiosurgery, we call it hypofractionation. What it means is that you give a dose is required for, but it's still a focused treatment, but you give the dose less than what is required ideally because the lesion is large. Then after some time, maybe a month, you repeat the dose, but cumulatively slightly higher than the initial, than what is required for that tissue. Let me give you an example. If a tissue requires 14 gray and you are hypofractionating, you probably give 10 first and 10 later. Theoretically, I'm just giving for example. So in effect, cumulatively is 20, but because you've given it at different intervals, however, focused irradiation, it becomes 20. If you get what I'm saying. My teacher, Adil, is watching, Professor Melhawi. He will contribute later. That is the basic question in radiosurgery with hypofractionation. Okay? Dr. Kabulo, have you got that?
Yes, Professor, thank you so much. Thank you so much for the answer.
Okay, Naru, did you have a question? Or I'm sorry, Joseph. Joseph, do you have a question? I believe he texted me.
Obande, you can unmute yourself before you speak.
Go ahead, Joseph.
Okay, thank you very much, Dr. Jimo. It was an excellent presentation. Thank you so much. I was wondering, in times past, the ethical dilemma of using radiation to treat non-malignant condition was a big issue with gamma knife and non-malignant management of non-malignant lesions. With your current experience, what's your take on this issue? Thank you.
Thank you so much, Obande. That's a good one. Shot at it. Now, going by the biology of the treatment, which I think I didn't emphasize on, the treatment is based on the irradiation to a pathological tissue. And that pathological tissue, it is known that irradiation to the DNA or RNA alters the tumor or the lesion, either vascular functional. It alters the function. Thereafter, it acts at cellular level, and thereafter, it acts as tissue level. Is cell death quite all right, but it's not like cell death that needs removal. Is there like apoptosis that remains within the tissue? Okay, now, why it is not much an ethical issue is the result we get and the long-term complication rate, which is far, far, far less. Of course, you say you are irradiating the brain, there is a chance of secondary malignancy coming up, but it is known over time that the chance for that is extremely low. It, of course, it exists, but it's extremely, extremely low. So ethically, I don't think there is any doubt currently as to the treatment use of a gamma knife in treating intracranial pathology. Yes.
Thank you very much. I appreciate it.
Joseph. Melhaku, do you have any comments or questions?
Professor Melhawi?
Okay, I'm just want to congratulate my friend Abdullah for his excellent talk, and I hope everyone got the message. I think the questions there, first question was about the tissue reparation, the differential effect. But for me, that was very interesting to share these aspects. And thank you again, Dr. John, for all what you are doing for our colleagues. Thank you.
Okay, very good. Any more comments or questions from the other panelists?
Hello, everyone, and
hello, Naru.
Hi, John.
Welcome.
I hope you are doing well. I want to thank Professor Jimo for his excellent talk. He make a great work, and everything was summarized in his presentation. And I would like to congratulate him, and I would like also to say big thanks for my professor Adil Melhawi, with who I start my first steps in neurosurgery, and I am recognized about everything they done for me, and I am so happy to see them today in this panel. And I remember the first time he showed me how to fix the frame, and I will never forget that. So I'm so happy to see you again, and I don't have anything to say. Everything is clear. Everything I noted, it's clear for me. So congratulations, Professor Jimo. You summarize everything in your presentation. Of course, you can say all about radiosurgery in just one presentation, but I would encourage everyone who wants to know and to learn about radiosurgery to come in the Rabat Center in Africa. It is the first center who opened the door for everyone who wants to learn about radiosurgery, and it will benefit for everyone and everywhere area in Africa. Because nowadays we should all of them to have a one motto. It is do not harm, and in this philosophy we should always think about radiosurgery, and the education it is also clear. So why not? Thank you.
Thank you so much.
Yes, Nuru is speaking next week. He's going to speak about spinal cord injuries, right, Nuru?
Yes, John, I will try to speak next week, yes.
Okay, very good.
Yeah.
He's given a lot of talks.
Yes.
Okay, any more comments or questions? Zolo, do you have any comments or questions? I know you're kind of challenged there by the bandwidth. And by the way, if you're in a low bandwidth situation, you can turn off your picture like I'm doing now because that saves bandwidth. That saves bandwidth if you're ever in a situation. Anyways, a little tip for the trade, Nuru. Okay, any more comments? Samuel, do you have any comments or questions?
I have a question.
Go ahead, Samuel.
Thank you so much, Dr. Jimo. You have indeed made us proud. This is an excellent presentation. I'm sorry I joined late, but I got a lot of information from your presentation. I just have a question, which I hope would have a surprisingly good answer. Are there any prospects of having gamma knife radiosurgery in your center when you return here in Zaria, Nigeria, anytime soon?
Okay.
Welcome.
All right.
Welcome.
Thank you so much, John. He's my resident. The fellow that Samuel Ghana is my resident. And I have to say at this point that indeed, that is the essence of being here. We are making moves through the hospital administration and through the Ministry of Health to see the possibility of acquiring one. The gamma knife itself costs about from $4 to $4.5 million, which in Nigerian currency is 1.5 billion naira. It's something that is quite much, and we are hoping that we'll be able to get one. The primary fellowship here is a stereotaxy. Generally, we'll start with that and subsequently upgrade into having the gamma knife form of treatment.
Are there any centers in Africa, doctor, at all? Any gamma knife centers at all in Africa?
No, it is just in Morocco. No.
And Morocco is the only one in all of Africa?
There is in South Africa and Egypt are made to understand by Professor Melawi. If he's still there, can he confirm that, please?
Exactly. Egypt, South Africa, and Morocco till now. 3 centers in Africa till now.
Okay. And they all have the latest icon gamma knife.
I'm not sure all of them, but at least perfection is in the 3 countries, I think.
Okay. At least Morocco has a icon for several years now, and the first to have it in Africa. In fact, the first to have the perfection in Africa and the first to have icon in Africa. And that's quite impressive.
Yes, indeed.
Very good. Okay, I really appreciate everyone coming out, and thank you, Abdullah, for an excellent talk, and I hope to see you a lot more. I have Endal, Samuel's, and Joseph's email address so that every presentation we have, you'll be getting an email announcing it. For example, when Naru speaks next week, you're going to get an email with the link to enter the panel if you have time at that point. I know how the life of a neurosurgeon, sometimes you can't predict on a Saturday, so, but you certainly will have the option to say, hey, I want to jump in the panel here and comment with this talk. Or you may just want to watch it on rounds, whatever. So anyways, thank you everyone for coming. And
I wanted, if Adil is still there, I wanted him to make an input into if there is any area of doubt or gray area for him to emphasize based on my presentation, you know, because he's my teacher here. I want him to clear certain things that might need to be cleared for records.
Oh, okay. Okay.
Are you still there?
Yeah,
Sure.
of course, my friend Abdullah, as we reviewed, we see that your today presentation was even more complete, and for me, that was really perfect. Congratulations to everyone.
Thank you so much.
Okay, very good. Abdullah, we'll talk after, and I'll just send this right now, okay?
Okay, thank you.
Okay, thanks everybody.
Thank you.
Okay,
okay, we're off the air, Abdullah.
Bye.
Okay, we're off. Now, do you want a letter, a participation from me, right? From Neurosurgical TV?
Pardon?
You wanted a letter saying
that would be great. That would be nice.
Yeah, okay. Okay, yeah, no problem. No problem.
Thank you. Thank
you. Yeah, does anybody else on the panel want to say something? Endal, do you have anything? She's a medical student, I see, from Cameroon. Endal, do you want to say something to Abdullah?
No, I'm, thank you so much. I've always participated in this, platform, citing. I remember in November when Bankole introduced me to the panel, the first session, Ulrich and Dr. John asked me that I should make preparation to present soon. And it's been in my mind, you know.
Really, yeah, but a lot of guys say that. They don't do it. You did it. You did it.
So I see this opportunity with the help of my very good friend and my very good my teacher, because he has so much that he needs to teach. But, you know, with his help, I'm able to go to Professor Adil Melhawi. Thank you so much for everything.
Yeah, we'd like to get Egypt more involved. We'd like to get Nigeria more involved in the neurosurgery broadcast. And we're certainly willing to broadcast anything they would like to.
Okay, and it's a platform that I want people from my institution to participate, and I'm very happy that I have 3 people now. Obande was in Morocco. I came with him to Morocco in 2007. That's a long time ago. And has not been here. And Ghana, I don't think has been here as well.
So this came to Rabat in 2014 with you.
Okay. I came with him to Rabat. It's only Guga that has not been here, I think.
Yes,
sorry.
I'm the only one left out, apparently.
No. You come here sometime. You come and see this wonderful center. I really encourage everybody, anytime it's going to take place again, you participate. Dr. John now has your email address. He will forward notifications to you so that you can participate in very serious discussion on this platform. Thank you so much, everyone. I'm very happy to have participated.
I want to confirm what you said, Dr. Jimo, that Professor Melhawi is one of great teacher about radiosurgery, not just about radiosurgery, about neurosurgery schedules, and it will be better and nice for us to have you, Professor Melhawi, in this panel. I know you are so busy. I know very well that it's not easy to have you, but we would like to have you maybe one times in 3 months if you can done like upgrade, updates about radiosurgery. I remember I worked with you about pituitary adenoma with Professor Wahabi about functional adenoma and non-functional adenoma, how to treat that, and it will be nice to come back about the chapter about the pathology, how we treat that, and the follow-up and the outcome. It will be.
Of course, my dear friends, that was my point also. I was very happy and proud to participate this first time with you, and I hope that will not be the last one. I'm ready, as you can know, whenever, I mean, there is a topic you want to treat, I can be in the line on the panel, I can treat any subject you would like. That will be my pleasure. Thank you again.
Do I have your email address, Malakwi?
Yes.
Oh, you do? Okay, so you get my emails now, right?
Absolutely, absolutely.
Okay,
Since
very good, very good.
Thank you for all that.
Yeah, any of the conferences, you're welcome to jump in the panel.
Thank you.
We even had one on the coronavirus.
See you soon next week, Professor Melhawi in Morocco. See you soon next week.
Okay, okay, that's good. That's good.
Yes.
Bye, everyone.
Yeah, bye. Okay, bye, everyone. We're going to sign off. Thank you all for coming.
All right, thank you.
Thank you.
Thank you.
Thank you. Bye.
Bye-bye.